Welcome to Injuries and Evidence, the podcast where real-life injuries meet real-life science. I'm your host, Jason Wardell. Dr. Carter and I this morning were talking about pain, chronic pain versus acute trauma. And we had a patient where the insurance is denying validity because he does have chronic pain. So we're looking up what research is associated to chronic pain versus acute pain and how to quantify that, especially if you're doing a final exam like an impairment examination.
Yeah, the biggest concern that I'm seeing, and I've seen it for many, many years in practice, especially in personal injury, is that the patient will have multiple body parts that are injured. And then...
So like head, neck, back,
sure,
ankle, hip, whatever.
Yep. And then what'll happen is like they'll come in and their chief complaint, which we always say chief complaint, which I think is, I don't know. I don't like that because like...
They're all complaints.
They're all complaints, right? They're all body injury. That's, you got to figure that out. So I guess chief complaint kind of means
what's hurting the worst,
what's hurting the most, with the patient. Your focus at the time, maybe more acute situation, and say like headaches or head injury, dizziness, et cetera. And so I've seen patients with head injury, and then they have neck pain, and that's about it on day one, after a whiplash type injury. Let's remember that even whether you're using Croft guidelines or Quebec Task Force, whiplash associated disorder types, however you're rating the patient's injuries, that they can have neck pain and headaches, and the WAD or whiplash associated disorder is like your focus, and then they have low back pain maybe a month later, month or two later, and or maybe they have some knee pain or leg pain, and then they always come in and they'll go, yeah, my headaches are going way down, my neck pain's going down, man, all of a sudden I'm getting this right knee pain, and they've never had it before, never experienced it before, and so then they're super confused. There's a lot of research behind it, and we'll just keep it short, but it's like that's something that we call central sensitization of nociceptive pathways, and that comes down to the nervous system, and the nervous system can actually turn on and off certain pathways, right? Pain receptors, and so maybe the focus is on the brain, and then also, and they don't feel knee pain, or they don't, whatever other subsequent complaint is going on with the patient, and maybe they don't feel it, but then as one area starts to heal, the other area starts to flare up a little bit, or they start to recognize it more.
Yeah.
And maybe it was actually, maybe they have a torn meniscus in their knee. They didn't even know it, and because they're focused on the head injury or the headaches or the neck pain.
So it's like your nervous system damage control going, hey, this part is hurting the most, instead of just overwhelming your body with like pain everywhere, because then if it's everywhere, it's nowhere. So your body's like focus here, then focus here, then focus here, and it goes through like the most severe to once that one is to the point where your body, it hits a threshold of like, you can manage this now, then it moves and you're like, my hip hurts. Like, why is this killing me?
Isn't that fascinating though? If you sit down and think about it,
yeah.
And it's like, and then there's people that are like, including physicians and stuff that won't believe the patient. And they're like, hey, I don't think it has anything related with the injuries you're involved in. Although they haven't had this problem before in the past, it becomes very subjective. It's just based on their opinion, their complaint. As a clinician, though, that's your job to take that in and then say, what, let's do an exam on you, try to figure out what's going on. And, sometimes it may lead to imaging and may lead to, more trying to rule things in and out with that. And the imaging may actually come back negative, and it's like, but they still have the complaint. Does that mean that the pain is not there? Well, based on all the studies that are being published, I mean, especially from AMA guides, like this is the 5th edition, but when they get into, you go to page 566 and they talk about pain, and this is what I like. You go to overview of pain, and it says pain is a plural concept with biological, psychological, and social components. I mean, you got to think of that, right? Biological.
Most people think it's just biological.
I know they do.
Well, I guess there is a psychological component to it. That's where you have malingering tests.
Well, can't you imagine if you're in a rollover crash or something like that, right?
PTSD.
PTSD. I mean,
Yeah.
maybe the anxiety, maybe it's triggering certain things. And, it's really difficult to examine a patient, and that's all you're doing is examining the patient, taking a patient history, doing some range of motion, orthoneuro tests. It's really difficult to conclude something, right? But you can come down to a diagnosis of saying it's more likely than not caused from the crash, according to the exam that you've provided for, the insurance company or for whoever you're doing it for.
So that mentioned biological and psychological and social. What do you mean by social pain? Like pain associated to social interactions? Is it like emotional distress? Because I still see that as psychological. What would be social there?
I think it's more cultural. Like when you're talking, it's social.
Well, suck it up kind of thing.
There's some people that say that, right?
That's my brother-in-law on a farm. It's
there you go.
You get hurt and just move on.
Hey, don't forget the neurologist that I have that I love. I think he's amazing. He's a genius when it comes to neurology. But what does he say when he worked in a hospital, and down in Texas? He said he had so many different cultural people coming in.
Yeah.
And depending on what part of the world they were from, that some people came in and they were like, I'm fine, and they're missing their right arm.
If a rancher or a farmer comes into the ER, it's like, that's code red, like whatever. Get over to
That's
them.
right. They're like,
they don't go into the hospital.
Rip the nail out of that foot. It's like, and then he's like, I'm good, whatever. But then you might have another culture that's a little more sensitive and has a little more, so depending on how there are so many social,
interesting
cognitive factors.
Gosh, I never even thought of that.
Pain. So they do say its perception is influenced by cognitive, behavioral, environmental, and cultural factors. At first glance, it seems at odds with scientific medicine because of the difficulty accounting for it with obvious pathophysiologic changes. Pain is subjective. It is subjective. You just have to rely on the patient's concern.
And it's different for everyone else, so you can't objectify it against like standards.
Yeah, and how many times have I heard it in practice where the patient says, I have a high pain tolerance. I'm not sure exactly where I'm at right now, but I have a high pain tolerance. So your 8 out of 10, maybe a 2 out of 10 to that farmer, or whatever. Yeah. So it may be a whole different pain level. It says its presence cannot be readily validated or objectively measured. Physicians are confronted with ambiguity as they attempt to assess the severity and significance of chronic pain in their patients. In large part, this stems from the fundamental divide between a person who suffers from pain and an observer who attempts to understand that suffering. Observers tend to view pain complaints with suspicion and disbelief, akin to complaints of dizziness, fatigue, and malaise. As Scary remarked, to have great pain is to have certainty. To hear that another person has pain is to have doubt.
Wow.
I think it's a great thing to ponder on, though,
when
it comes down to complaints, right, and to pain.
Where everyone looks at him like doubting, like, you're not that hurt.
Yeah.
And, we've actually heard that from some patients when they've come into us. This was 2 years ago. We were working with a patient, and she came into us, and she was like, no one believes me. Like, I am hurting every day. And we did some tests on her, and she had disc herniation. She had a whole bunch. She was kind of wrecked and had concussion symptoms, and got her in for some concussion evaluation and rehab. But I just remember that it was really, really stark because when I was doing her intake and onboarding, she was like, no one believes me. I hope you guys at least believe me and try to figure out why I'm hurting because I feel crazy. I remember that, and it was like, gosh, is no one believing that this woman's hurting? And I understand malingering, like maybe there's a psychological component to hyperreactivity to pain where it's almost blowing it out of proportion. But this one was, it was like a real case.
Faking.
They're not faking it.
It's
like
just a hypersensitivity
at
the moment.
Maybe they're going for attention and there's a psychological component, like a social thing. Could be. I am more in pain, thus I get more love or like care or things like that. So I understand that, but I just remember that case and how distraught that woman was because no one believed her. She's like, I'm hurting really bad.
Well, if you ever want to look up there's some amazing studies on central sensitization of nociceptors, and these pain receptors, they can turn on and off, and it's very when it comes down to the central nervous system, and that's what we're talking about with central sensitization, is that the pain can start with a psychological component, and maybe you turn off the pain receptors, maybe you turn them on.
Can you mentally
How many times
do
have
that?
you ever mentally shut off pain though? I've done it many times where I'm like, ooh, I dislocated my left shoulder one time many years ago, and we were up at Lake Tahoe, and I dislocated it, and I knew I had to camp for 3 more days, and the pain was so bad at night. I mean, like when I laid down, oh man, I mean, it was like, it felt like someone sticking a razor blade right into the armpit, and it was so bad. And I just had to talk myself out of it, that like, I don't have any pain. And I would say that it started calming down. And then when I started thinking about it again after I got home to go get an MRI, it was like, oh, it's killing me, because they start moving it again. It was, with the torn labrum in there. And
also makes me think of those monks that get like smacked with canes, and they're just
study,
like, ooh, and they just take it like a champ. It's like, man, they are mentally just blocking out, like turning them off. It's like, I don't feel. I wonder if MMA fighters or like boxers, if they go through that, like because I imagine like your epinephrine, norepinephrine levels when you get into a fight or flight, if you're getting ready to like really fight, I wonder if your body closes those off in those situations.
Totally.
Like right after an accident, someone gets traumatized, there's like immediate adrenaline pumping through their system. That's probably why a lot of times like I didn't hurt at first, but then after, it's like 20 minutes after when those started metabolizing and breaking down, they're like, I was really hurting.
There's great studies on adrenaline, and like it can even be 8 to 10 days later, as the adrenaline starts to wear off, depending on where you were at the moment of the impact, right?
Yeah.
Adrenal glands, go do a little homework on it and see how much we pump as humans, and what if they already were hyper stressed and they have high levels of adrenaline, and then they get in the crash, and now it's really maxed out, and then a week later they're like, man, what is up with my neck? It is now the pain's starting to set in. That's still an acute pain situation, up to 4 weeks, and it's like, so you can't turn that down, although as an observer you're like, seems weird that they would have the pain, but great studies on malingering and faking, or whatever, and it's a very minimal amount of patients will even be malingering, or and they even say that in AMA guides when there's a section on malingering.
Do you do malingering tests with every exam?
Yeah, absolutely. Yeah, so there are multiple behavioral tests, behavior analysis is what I call it, and they're behavioral tests to see how the patient responds to it, and if they are, is it a positive or negative test?
Waddell sign.
And then Waddell sign's another thing as well. A lot of people use those wrong. Waddell was trying to figure out, is there a psychological component, yes or no? And so there's 5 different tests, and if it's 3 out of 5 are positive, then if 3 out of 5 are positive, then there is a psychological component to it. Does it mean they're faking? And in the personal injury world, then yes is the answer. That's usually what they're looking for, right? Are they faking? Well, really, Waddell designed it to see if there's a psychological component to this. Like they're actually thinking it, like maybe they're
like trauma,
exaggerating in
like
some way.
The trauma is actually making it mentally more hyper-reactive than really what actually occurred.
Yep. Yeah, and you can do, and again, we can even go down the line of someone really faking, right? They come in with crutches, and you watch them walk out to their car, and you're like,
have you seen that?
Toss the crutches,
Like with exams?
I never have seen that out of the thousands of personal injury exams. I've never seen that. I did have one time. There was an exam that I did do.
Was it the tickle with the foot? And she's like, "Oh, my back." I remember that one. That was actually pretty funny.
Yeah, I've only seen that one time where it was like, Like that causes low back pain. That's
like
really
hyperreactive malingering tests.
Yeah, that was pretty obvious though. You
Yeah.
know that person was just, and you don't know if they're faking it or something for gain. You know, I'm not. But who am I to judge that situation, other than just say, hey, it is positive. There is a psychological component to this. I don't know if they're doing it for gain or are they hypersensitive? Are they, where's it at? I don't, again, it says even right here, and if you go to page in the AMA Guides 5th edition, they even have a section on malingering. And where's it at? And it's behavioral confounders. And the last one it's 18.7. And it says malingering is conscious deception for the purpose of gain. And, and that's a good definition of it. It says Fishbane et al. Reviewed literature suggesting that malingering is present in 1.25% to 10.4% of individuals with chronic pain. Still in the lower end. It says, however, they found serious flaws with the methodology in the study and concluded that no conclusions could be drawn from the data. So AMA Guides they look at they do look at some studies though. That one's not the best study, obviously. It just kind of tanked. They were like, well, it doesn't really work. There's some flaws here. There are some other exaggerated hearing tests that people had, but still it's around 14% to 17% of the patients were exaggerating. Yeah. And so, it's still on the low end, and it's not like, a lot of times from a clinical side, I've heard people say like, oh man, they got to be faking it. And it's like, well, really, if you're seeing thousands and thousands of patients every year,
sure,
then
you probably have a percent or two.
1 to 5% is pretty low. So,
do you see more inconsistency, not necessarily with malingering, just because like a physical malingering test, but do you see more inconsistency with mechanism of injury, like how it actually happened, and current complaints, like onset of initial complaints? Because when you're looking at medical history for a patient, when you're performing an impairment exam, you're looking through 5 to 10 other physicians' notes and what their causation statement, their mechanism of injury, and even areas of current complaint when they go in. Like, do you see inconsistencies there? And you're like, there's
not too often.
Not too often.
And I think that's something that's very important, though, as an impairment examiner. That's your job. You're supposed to compare records, right? You're supposed to analyze all the records and go, is there any inconsistency with the records? And I would say no. I haven't seen that. Like I said, the one thing that I've seen is like a complaint that comes on maybe 4 to 6 weeks later.
Just a delayed response with pain.
Yeah, and so
I think of that.
Who am I to judge that situation? We got to think of that central sensitization situation, and you got to think the body. I mean, there are some great studies even where they're injecting saline into one part of the leg of the patient, and it causes pain, and then the pain is referred to the left leg with some patients, and it's like they didn't know they got it in the right leg, but the pain is felt in the left leg. And it's like, so is that neuropsychogenic type pain? Is it a neurological situation there? The thing is with pain, we don't understand it.
We feel it. We don't.
We act like we do.
We
think we understand it.
There's aspects to relieve it.
Yeah. And I remember or
methods.
Neurology class I had many years ago, probably almost 30 years ago. And I remember the professor saying that, he was super humble compared to some professors that we had in the neuroscience world. And they'd be like, we know everything about the brain. We know the way this whole thing functions. We know, and you're going to fail. And all of you are jacked up, man, by the end of this semester or whatever. Because you're not going to know anything about the brain because we're the geniuses and you're not. That drove me crazy. But I do remember a neurologist that was really humble, and he said, we know less than, right now, we know less than 1% about the brain. And that was
So you're
30
saying
years ago.
there's a chance.
I know, that's a good point.
Like 1 in 100, 1 in 1,000.
It's more like 1 in a million.
So you're saying there's a chance.
Yeah. So to have a to know less than 1% when it comes down to it, that makes me really makes me think.
That's wild.
And it's, again, you got to do the examination the right way. You got to take that history. You got to do, you got to get the imaging done. You got to make sure that you're connecting the dots and you're really taking the patient down that treatment lane. And do we know the answers to everything? No, we don't. But, are we at a point where we can change a person's life with certain types of treatment nowadays? Yes, absolutely. We can help them improve, but it's not a cure-all to everyone. Yeah. That's why we have permanent and permanent exams.
But it's quantifiable data against pain.
Yep, to understand it and to actually give a percentage on a whole person impairment.
Yeah.
And
loss of function.
Yep. And then, I like to use AMA Guide's 5th edition, but also the 6th edition. It's and there are so many different. You can use the newsletters and everything from the AMA Guides, and they'll give updates on it, and that really helps us through this entire process of really quantifying how bad the injury is.
I love it. Well, thank you. That was insightful. I hope you guys learned something about chronic pain and acute pain, and your patients, your clients, your customers, people you interact with that you are treating through personal injury or even work comp, they're not faking it for the most part. You have 1% that are, 1 to 5. So
very minimal.
Yeah. Believe your patients, believe your clients, help them through that.
Yeah,
if you need someone to give them an evaluation, reach out to us, info@pisciences.com. We'd love to support you and support your clients and help them get the treatment that they need.
And what I think that everybody needs to read is that study on central sensitization, because it does go through the different sensory.
I'll apply the link in the description of the podcast and in the video. Check out the link there. I'll have the link to the research study. Take a look at it for chronic pain.
Awesome.
Okay.
All right.
Thank you, Dr. Carter.
Yep, you bet.
Anyways, tune in on YouTube, Apple Podcasts, and Spotify, and on our site at www.pisciences.com. See you on the next one.
Have an awesome day.
Thanks for listening to Injuries and Evidence. If this episode added value, subscribe to PI Sciences and grab our free gift, a 60-minute training called A to Z in Personal Injury. It includes all the tools we use every day to strengthen documentation and improve case outcomes. The link is in the show notes. Use it. Don't leave value on the table. We'll see you on the next one.